My name is Torin Saul. I'm from St. Luke's Roosevelt Hospital Center, and today I'm going to be talking about ocular ultrasound. Ocular ultrasound can be used for a number of different indications and to look for a number of different pathologies. The eye is a very easy structure to ultrasound because it's fluid filled, so it transmits ultrasound waves very easily. Some pathologies you can look for when doing ocular ultrasound are retinal detachment, vitreous hemorrhage, vitreous detachment, ocular foreign bodies, lens dislocation, retrobulbar hematomas. You can evaluate the pupillary light reflex, and we'll also talk a little bit about how ultrasound can be used to evaluate the optic nerve sheath diameter. First, some contraindications to performing ocular ultrasound. First, if there's any obvious or suspected globe rupture. In these kinds of cases, you don't want to perform ocular ultrasound because you don't want to apply additional pressure to the potentially ruptured globe and cause more damage. In addition, if there's significant periorbital injuries, again, you don't want to apply additional pressure with the probe as it may cause the injury to become worse. Also, you can, in cases of suspected clinically significant retrobulbar hematoma, you might not want to perform ocular ultrasound as it can cause increased pressure on the globe and potentially cause further damage. So in those cases, the reason we don't want to perform ocular ultrasound is that any pressure on the injured eye could be detrimental. If there's any suspicion for globe rupture, we probably shouldn't be performing it anyhow. But if it's low on your list, but it is still a suspicion, you want to make sure you use copious amounts of gel to the closed eyelid. So you can still transmit the ultrasound waves through the gel without applying any additional pressure. It should also be performed by someone who has some experience to make sure that absolutely no additional pressure is applied to the probe. Not necessarily a contraindication, but just something worth mentioning is if there's any orbital emphysema. In these cases, you might not want to perform ocular ultrasound because the emphysema, the air that's in the tissues, will block the ultrasound waves. Ultrasound waves do not like air. It causes them to scatter in different directions. So if there's significant orbital emphysema, you're likely not going to be able to visualize the structures below and do a thorough evaluation of the globe. Some basic anatomy of the eye. In the back portion here, this is an ultrasound image on the left-hand side of the screen. This is the vitreous humor. Superiorly on the image, this is the anterior chamber. And then between the two is where the lens is located. Posteriorly, you can see that hypoechoic or darker structure there. That's the optic nerve. And this whole area behind the globe is the retrobulbar space. As for the scanning technique, you want to use the high-frequency linear array probe. Here's an example on this ultrasound machine. The circle represents the high-frequency probe. And you want to use high-frequency probes for this type of scanning because you don't get a lot of tissue penetration with the high-frequency probe, but you do get much better resolution of the image. And the eye is a fairly small structure, so you don't need a lot of penetration, but it's nice to have good resolution so that you can evaluate all the ocular structures. Here we have a video of someone demonstrating the scanning technique. So first he's going to apply a occlusive dressing to the outside of the closed eyelid. And this is in an attempt to keep the eye as clean as possible. So you have the patient close their eyelid and apply an occlusive dressing such as Tegaderm. He's careful to smooth out all the air bubbles underneath the Tegaderm, as again, air will scatter the ultrasound waves. You now want to apply a water-based lubricant, Surgilube is being used in this example, to the outside of the tegaderm dressing. And here the operator is applying additional Surgilube to the outside of the tegaderm, again to use copious amounts of gel to avoid applying pressure to the globe. The operator is now going to use the high-frequency linear probe and apply it to the closed eyelid. The operator is placing his fourth and fifth digits there, either on the patient's nose or cheek, and he's scanning in the transverse plane. Applying the fingers to the bridge of the nose or the cheek will help not only stabilize the hand, but keep it from applying additional pressure. So then the operator rotated the probe and scanned in the sagittal plane as well. Again, just to reiterate, the probe is placed in the transverse plane, probe marker to the patient's right, and then the probe is rotated 90 degrees over the orbital rim, and the eye is scanned in the sagittal plane. In this image, the operator is actually using their other hand and using the patient's cheek to stabilize their hand using either their fourth or fifth digits. So here's a short video clip of someone performing ocular ultrasound. Again, just to go over briefly some of the anatomy. Posteriorly, there's the vitreous humor. On the top of the screen there, when it comes into view, there you can see the anterior chamber, and then just posterior to that is the lens. So the first pathologic state I want to discuss is retinal detachment. So the normal retina is continuous with the other posterior elements of the globe. When retinal detachment occurs, fluid enters that potential space beneath the retina, and you can see the retina floating in the vitreous as a thick hyperechoic membrane. Here's a video clip of retinal detachment. You can see there that as the patient moves their eye to the left and to the right, there's a hyperechoic membrane that's as would be normally adherent to the posterior surface of the globe, now is detached. And you can see it actually moving back and forth and undulating in the vitreous as the patient moves the eye back and forth. So this is a patient who had a retinal detachment. The second thing I want to talk about is vitreous hemorrhage. Vitreous hemorrhage appears as echogenic material in the posterior chamber, and how it's going to appear sonographically depends on the age and severity of the hemorrhage. So a hemorrhage that's just occurred might appear as small dots or lines. Older hemorrhages, however, the blood starts to clot and organize, and it can form membranes. And with time, the blood that's in the posterior chamber and blood products can layer dependently due to gravity. So here is a patient who had a vitreous hemorrhage. You can see there's some small dots and lines in that posterior chamber in the vitreous. Perhaps there's even some organization starting to occur with membranes forming. You could see the swirling motion of the debris in the posterior chamber as the patient moves the eye back and forth. Next, I'd like to discuss vitreous detachment. Vitreous detachment can be confused and is similar to retinal detachment in its sonographic appearance. So there's a couple of things you want to look for to differentiate the two. Similar to retinal detachment, there will be a hyperechoic linear density in the posterior chamber. Some things that help differentiate it from retinal detachment is that it's generally thinner and smoother than the hyperechoic line seen in retinal detachment. Retinal detachment will remain anchored at the optic nerve site, whereas vitreous detachment, this actually, because it's not adherent to the posterior surface, um, will occur in front of the optic nerve. So the entire thing may be disrupted as opposed to being anchored at that optic nerve site. Um, Vitreous detachment can be somewhat difficult to visualize. You may have to increase your gain settings in order to see it. Here's a short video clip of someone with vitreous detachment. You can see there's a thick hyperechoic membrane floating in the posterior chamber, but different from the retinal detachment, it crosses over the area where the optic nerve inserts, whereas in retinal detachment, it is anchored at that point. You can see there's probably also a small degree of hemorrhage there, just anterior to the vitreous membrane. You can see as the patient moves the eye back and forth, the membrane moves along with it. Ocular foreign bodies usually appear hyperechoic. They can have some shadowing, they can have reverberation artifact, but it really depends. It depends on what the foreign body's characteristics are. So the patterns of shadowing or reverberation can give some information about the material. For example, if it's a metallic foreign body, it will probably cause a reverberation artifact, similar to when you see the ring down artifact when performing vascular access. You can see a patient who has a foreign body in the posterior chamber, very small punctate area. Right, in the posterior chamber. And this area in the posterior chamber is usually completely anechoic. So any kind of hyperechoic densities could be concerning for an ocular foreign body. Lens dislocation is a fairly rare phenomenon. However, ultrasound can be used to detect it. The lens can be seen as a hyperechoic disc floating in the vitreous. Because many times lens dislocations are traumatic, there might be also hyperechoic areas of hemorrhage in the vitreous. Here's a short video clip of a patient who had a lens dislocation. You can see the lens is not at that normal interface between the anterior and posterior chamber. However, it's displaced posteriorly and dislocated. You can also see that in that normally anechoic area of the posterior chamber, there's some areas of varying echogenicity, so that's likely some hemorrhage back there as well. I did want to talk for a few seconds about globe rupture, although as we discussed, if this is something that is high on your differential, you're seriously considering this patient has, you shouldn't be performing ocular ultrasound. You should be obtaining emergent ophthalmologic consultation. But if for some reason you do see these findings, I want you to know what you're looking at. So sonographic findings of globe rupture include decreased size of the globe, collapse of the anterior chamber, some areas of hemorrhage, and buckling of the sclera. Here's a video clip of a patient who had a globe rupture. Again, you can see that there's some buckling of the sclera. The anterior chamber is completely collapsed. And if you had compared this to the other side, the globe is not the same size. It is smaller as a result of some of the fluid having leaked out. Ultrasound can be used to evaluate retrobulbar hematoma. You can see the area, the retrobulbar space on ultrasound. And if there's a hypoechoic collection posterior to the globe, that could be concerning, especially in the right clinical setting. the retrobulbar hematoma can displace the optic nerve. So here's just a picture of a normal eye. There's no retrobulbar hematoma here. I just want to point out the retrobulbar space. So you can see there's this hyperechoic area posterior to the nice anechoic globe. And it's normally fairly uniform, except for that area where there's the optic nerve further to the left. However, if you see a hypoechoic area posterior to the globe in this area, it could be concerning for retrobulbar hematoma. Another interesting thing you could use ocular ultrasound for is to evaluate the pupillary light reflex. In patients who've had significant orbital trauma, the physical exam can be limited. If you can't open the eyelids due to significant periorbital edema, you aren't going to be able to assess the pupillary response. So in these cases, ocular ultrasound can be used. So the way this is performed, the pupillary light reflex is evaluated, is again, you use the occlusive dressing on the eye, and you can place the probe on the closed eyelid in the transverse plane and angle it so that you're looking up at the iris. So use a fairly shallow angle. And you want to shine light into the unaffected eye while performing ultrasound on the injured eye. So what you're looking for is actually the consensual pupillary response. So when light is shined into the unaffected eye, there you can see on the right-hand side the video on the screen. You can actually watch pupillary constriction. And this can give you some additional information as to which of the cranial nerves are working. In this case, in the affected eye, you would know that the third cranial nerve, the oculomotor nerve, is working. Here, looking in this plane, it is subtle, but at the top of the video there, you can see the iris contracting and expanding and causing changes in the size of the pupil. So you can look at this in different planes, but generally the coronal one on the last slide is the one people use because it's the best way to visualize the pupil. Finally, I want to discuss the optic nerve sheath diameter. The optic nerve sheath diameter is used to evaluate for increased intracranial pressure. So intracranial pressure is transmitted through the CSF, and this communicates with the peroneurial subarachnoid space of the optic nerve. So it's thought that if there's increase in the intracranial pressure, it'll be transmitted along the optic nerve sheath and increase its diameter. So the optic nerve inserts medially onto the globe, so just to the nasal side, and the convention is that you measure it 3 millimeters posterior to the retina. So 5 millimeters is the cutoff. If it's less than 5 millimeters, it's not suggestive increased intracranial pressure, or if it's greater than 5 millimeters, it's suggestive that there potentially could be increased intracranial pressure. So here in the image on the right of the screen, you can see that the operator first measured 3 millimeters posterior to the surface of the globe and then measured the diameter of the optic nerve sheath at that site. Here's a short video clip of someone performing this measurement. Again, they're bringing up calipers to measure 3 millimeters posterior to the globe and then measuring the optic nerve sheath at that site. A couple of articles in the literature regarding this. So this article called Emergency Department Sonographic Measurement of Optic Nerve Sheath Diameter to Detect Findings of Increased Intracranial Pressure in Adult Head Injury Patients. This was from Annals of Emergency Medicine, and it was by Dr. Tayal and his team. And this was a prospective blinded observational study with suspected intracranial injury with increased intracranial pressure. So they used a mean binocular optic nerve sheath diameter, and they considered greater than 5 millimeters abnormal. As the gold standard, they compared it to CAT scan findings of increased intracranial pressure. So this can include effacement of the sulci, collapse of ventricles. There's a number of different things that are used as markers. So they were able to find that in this patient population, they had a sensitivity of 100% and a specificity of 63% when they used 5 millimeters as their cutoff. And their conclusion was that ultrasound of the optic nerve sheath diameter may be a sensitive test for increased intracranial pressure. Secondly, I'd like to go over this brief report, Correlation of Optic Nerve Sheath Diameter with Direct Measurement of Intracranial Pressure. This was done by Dr. Kimberly, Dr. Shah, Dr. Merrill, and Dr. Noble, and this was in Academic Emergency Medicine. So they performed a prospective blinded observational study. And what was nice about this study was that all of the patients had invasive intracranial ICP monitors. A lot of the studies done used CAT scan findings as the gold standard, but these patients actually had intracranial ICP monitors. They did 38 ocular ultrasounds, and they performed on 15 patients. They found that the optic nerve sheath diameter greater than 5 millimeters detected an intracranial pressure of greater than 20 millimeters of water with a sensitivity of 88% and a specificity of 93%. And this study is nice because their gold standard was the actual intracranial pressure. The third study I want to discuss was a pediatric study done by Dr. Lee et al., and this was in Annals of Emergency Medicine. The title, Bedside Sonographic Measurement of Optic Nerve Sheath Diameter as a Predictor of Increased Intracranial Pressure in Children. So they studied children from 0 to 18 years of age, and there were two main points of the study. First, they compared the emergency physicians to cranial imaging or invasive intracranial pressure monitor evaluation for intracranial pressure, using as a cutoff of 4 millimeters in children less than 1 year old and 4.5 millimeters in older children. So the emergency physicians, when using these cutoffs as predictors of increased intracranial pressure, their sensitivity was 83% and their specificity was 38%. As a second part of the study, they had an ophthalmic sonographer and a pediatric ophthalmologist also scan the patients, and these practitioners had a significant amount of experience doing ocular ultrasound. So compared to the ophthalmic sonographer, the emergency physicians had fairly good agreement with a kappa of 0.52, and compared to the pediatric ophthalmologist, the emergency physician also had fairly good agreement with a kappa of 0.64. So their conclusions were, for evaluation of intracranial pressure, given the sensitivity and specificity, they did not advocate using this as a screening test for increased intracranial pressure in children, that this evaluation was thus inadequate to really use as a screening test. However, they did say that compared to these other practitioners with a lot of experience in ocular ultrasound, that there was fairly good agreement between them and the emergency physicians. And emergency physicians are accurate at measuring optic nerve sheath diameters. So in summary, ultrasound of the orbit can be used for traumatic and atraumatic visual disturbances. You want to make sure that you avoid applying pressure to the globe. Use a copious amount of gel and a film barrier to keep the eye clean. And of course, as always, use ultrasound in conjunction with the patient's clinical scenario. Here are the references that I used if you'd like to view any of them further. And I want to thank SAEM, Dr. Herbst, Dr. Lewis, Dr. Lateplo, and Dr. Nagdev for their help in preparing this lecture.